Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers. Today, the devastating and unchecked measles outbreak in Texas. Dr. Bill Moss returns to the podcast to talk about the scope of this outbreak and what we know right now about how it's spreading, where, and why. We also talk about some misleading claims around treating measles disease with vitamin A, steroids, and antibiotics, and what individuals can do to protect themselves, including people who aren't sure if they have immunity. Let's listen. Dr. Bill Moss, welcome back again to Public Health on Call. We're talking today about the measles outbreak in the Southwest United States. Can you tell us what we know right now?
Yes, and great to be with you again, Lindsay. So what we know about the outbreak in Texas is, the state of Texas has been really good about posting on their website the information about the cases. They last reported their cases on March 4th, Tuesday, March 4th. They reported 159 cases this year in 2025. Most of those cases, 107 of those cases, are from a single county, Gaines County. And the number of cases has been increasing. And so with an increase of about 13 cases within the past week. Unfortunately, 14% or 22 of those cases have been hospitalized. And as many people know, there was one death in an unvaccinated school-age child, which is really tragic because that's a very easily preventable death. And that child had no underlying condition. So that was an otherwise healthy child. It's important for people to know that. Within Texas, so they have this ongoing transmission from this outbreak. They've also had some imported cases. They are reporting 4 cases that were associated with international travel. So they're still having new cases come into the country. Most of these cases are in school-age children between the ages of 5 and 17 years age. Most of these cases are unvaccinated or have unknown vaccination status. There are few children who received a single dose of a measles-containing vaccine.
What do we know about this outbreak in particular and the community in which it's occurring? And I know that there are outbreaks happening in other states in the area. Are they related?
Yes. So what we know about this community is that this outbreak started in a Mennonite community in Western Texas. Many of the children are homeschooled or in smaller private schools, and many obviously were unvaccinated. So this is occurring in a community where there are low vaccination rates. And I'll just say, this is not atypical for the larger outbreaks that we've seen in the United States. In 2019, we had a lot of measles cases in the United States, 1,274 over the entire year. There was a large outbreak in an Orthodox Jewish community, slightly over 900 cases. In 2014, there was a measles outbreak of 383 cases occurring in an Amish community in Ohio. So where we see these larger measles outbreaks tend to be in close-knit communities with very low vaccination rates for different reasons, perhaps for religious objections.
And do we know if they're related to some of the other outbreaks that are occurring in nearby states?
Yes. So the state with the next most highest number of cases is New Mexico, on the border there with Texas. And so we are seeing measles cases being kind of exported from Western Texas to other counties within Texas, but also to other states. And so we've seen measles cases in as far from Texas as New Jersey or in Kentucky. So what happens is that infectious individuals who may acquire their measles in Texas then move to other states. But we haven't seen outbreaks in other states of the size that we're seeing in Western Texas in that community with low measles vaccination coverage.
How do we stop this? How do we curb this outbreak?
Well, in some ways, it's a relatively easy answer. The way we stop and prevent measles outbreaks is through measles vaccination. We have a very highly effective measles vaccine with just a single dose, maybe on the order of 93 to 95% of people will be protected. That percentage goes even higher if they get their second dose as recommended, to bring that up to 97% or even higher. So the way we both prevent and stop these types of outbreaks is by people getting vaccinated.
What are the challenges to doing this?
Well, it can be challenging. As you know, Lindsay, I work in many countries in sub-Saharan Africa, and there the issue can be access. Just getting the measles vaccine to children who live in remote rural areas or children living in areas of conflict. Those are obviously not the challenges that we're facing here in the United States. Measles vaccine is readily available. So it's a problem on the demand side, and that's a complex issue, but it's addressing concerns about measles vaccine, having the right messenger, having the right people speak to these communities. In this situation, it may be religious leaders who need to be the trusted messenger and provide the information to address the concerns of the community, particularly in the face of an outbreak of measles, where, again, we've had one tragic death, 20% of individuals hospitalized. So it's really talking to people, listening to people, but trying to address misunderstandings and probably misinformation and disinformation that they're hearing.
Earlier this week, Secretary Robert F. Kennedy Jr. put out an editorial in Fox News talking about the importance of vaccination, but also claiming some other things may help, such as vitamin A and steroids. Can you speak a little bit to some of those?
Yes. So there were a number of kind of half-truths in that editorial. And, I was glad to see some of the statements advocating for vaccines, though sometimes in a backhanded manner, and talking about, the need to discuss with healthcare providers and the fact that it's a personal choice, and not thinking more about how this really impacts a community. It's really a community choice. There's a long history of studies, actually, Lindsay, by our former dean, Al Summer, here at the Bloomberg School of Public Health, who did the initial studies showing that vitamin A supplementation in settings where there's a high prevalence of undernutrition and vitamin A deficiency can prevent measles mortality. And if it's even given to children once hospitalized with measles, can reduce measles mortality. But it's very important to say a couple caveats there. First of all, vitamin A doesn't prevent measles virus infection the way the vaccine does. So children would still get measles. It doesn't completely reduce the risk of measles mortality, maybe cuts it in half or so. And then thirdly, the real impact of vitamin A is in communities or settings where there's a high prevalence of undernutrition and vitamin A deficiency, not what we see here in the United States. So vitamin A, although it can be given to children here in the United States under the supervision of a healthcare provider, particularly children who may be immunocompromised in some way, children who are hospitalized with measles, it's not a cure. And it's not a prevention. It reduces the risk of severe measles in children who acquire measles. So it's a fantastic tool in our armamentarium to trying to reduce measles mortality, particularly in high burden settings outside the United States. But it's not a tool to prevent measles the way measles vaccine is. Steroids are not standard therapy for measles. And in fact, measles can impair the immune system and set a child up for secondary bacterial infections like pneumonia. Steroids might only exacerbate that. There is a role for antibiotics in children who develop a secondary bacterial infection, such as pneumonia or an ear infection, but it's not recommended that all children get antibiotics either. So there's some truth in what's being said there. There is value of vitamin A supplementation, particularly, as I said, in settings where there's undernutrition or vitamin A deficiency. But there's not a role for steroids for children with measles in general, and even for antibiotics. And there is toxicity associated with vitamin A if children or any individual get too much of it.
So far, we've been talking about these outbreaks within these certain communities, but I know that a lot of people are really concerned about their own individual health and safety. There are concerns about someone got their titers done and they are no longer immune. Should they get a booster? There are concerns about people that are traveling through these areas and maybe have a layover in an airport. What do you think people should know about their individual safety if they're not living in one of these communities?
I would say, the first thing is for individuals who've had 2 doses of a measles vaccine, I would say you don't need to worry. If you've had 1 dose, there's a slightly higher risk if you're exposed to measles that you might get measles, although you'd likely get a milder course of measles. There are challenges with measuring your antibody levels because many of the tests are not sensitive at low antibody levels. And so individuals may be classified or misclassified as susceptible. And those individuals, if they have had a history of prior vaccination, are going to have what we call a memory immune response that's going to kick in. Their immune system has seen measles virus before in the form of the vaccine, and it's going to respond rapidly. So I don't, in general, recommend that people test their antibody levels for measles because I think it can be misleading. If there is any doubt about a person's measles vaccination history, it's very safe to get another dose of measles vaccine, and you don't need to follow that up with measuring antibody levels. The Center for Disease Control and Prevention recommends that for, traveling internationally, people should be sure that they're up to date on their measles vaccine. And the question then comes up whether that kind of advice is now applicable to parts of the United States. People have to kind of weigh the risk of where they're going and the risk of coming into contact with an individual with measles, recognizing that that's not easy to do. They'll also want to weigh their risk of getting severe measles. So, for example, people whose immune systems are weakened because of chemotherapy or underlying diseases, or for infants younger than 12 months of age. So there's no right or wrong answer here, but I think the simplest part of the answer is that individuals who've received 2 doses of a measles vaccine should be very confident that they're protected.
Would a mask help?
Measles virus is transmitted through droplets and through aerosols. It would need to be a tight-fitting, like an N95 tight-fitting mask that could reduce should reduce the risk. If it's worn properly, it should reduce the risk of coming into contact with measles virus.
Last question for you. This is obviously a very serious situation. You've also named 2 other times in recent history where we've had outbreaks, of this size or even larger. Where do we stand with this outbreak right now? Is it showing any signs of slowing down? What might happen next?
Yeah, well, it's obviously a little tricky to predict that, but we're not seeing signs of it slowing down. So it's a matter of, whether the virus will get into other communities where there's low vaccine coverage. So if we have, just to take an example from Maryland, we had 1 case of measles in 2023 and 1 case of measles in 2024. Someone was in the state with measles, but we have very high measles vaccine coverage in this state. And so we didn't get a larger outbreak. So we're going to get, in some states, there'll just be 1 or 2 cases in those states or those communities with high vaccine coverage. But if, someone from, let's say, West Texas who's infectious goes to another community where there are a large proportion of unvaccinated individuals, then we're going to get another large outbreak. And that too can seed other sites. So it's really a matter of, where the clusters of susceptible individuals are because they're under-vaccinated, and whether the vaccine gets into those communities to spark a larger outbreak.
Well, we'll certainly be keeping our eye on this, and we appreciate your insights. Thank you so much, Dr. Bill Moss.
Thank you, Lindsay.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.